mute, and Artem, Sandeep, and Pablo can take it away from here.
I think Pablo is logged in from 2 places. That's why his voice is echoing. So
where is the second one? I'll just.
both Pablo, are muted. Actually. Yeah.
Okay, Pablo, can you unmute one of them, and then you can talk. You're logged in from 2 places. Yeah. Okay.
What about now?
No.
So maybe try the other one. Okay, so he's just gone out. Sandeep, you and Artem could start, or Soto can start, please.
Yeah, no, I think. So who's going to introduce Joshi?
You guys decide. I have no issues.
Sandeep, you can do it, of course.
No, I didn't prepare for it. I didn't know that I had to do that, so I would leave you to do that. So.
I'm quite happy to introduce myself. I think I haven't actually met most of you. So Nicola and I have worked together, and I think he's joining a little bit late, but so. Would that be okay?
Mm-hmm. Yeah, perfect.
So my name is Joshi George. I'm a neurosurgeon in Manchester, specialize mostly in spine, but do a little bit of brain as well. Thank you very much for inviting me.
I think we should just start with your talk now, so you can share your screen.
Okay, great. Thanks. I hope you can see that.
Yep.
Okay, so I'm going to talk about a direct lateral extracavitatory approach for access to thoracic spine. This is primarily focusing on a discectomy, but it can be used for a corpectomy or an interbody fixation. I do have one disclosure to make. I'm going to be showing and discussing briefly a spinal marker, which I've been involved in developing. I want to stress I have no financial interests whatsoever in the company who makes it. So I'm very sad to say that if you all decide to use it, I still won't be making any money today. So I want to talk about this in the context of a patient I've seen. So this was a 52-year-old lady who I saw a few years ago. And she was referred by the neurologist saying that she had been having episodes of the right leg giving away for a period of about 6 years. And this had got worse over the past few months after having had a fall. And in terms of past medical history, there was nothing particularly exciting. She was a smoker. On examination, she had a spastic right leg with 4 out of 5 power, and she did also have some slight urinary urgency. So she came with this MRI scan, which showed a large disc protrusion at the T10-11 level, which is compressing the spinal cord with some signal change. And these are some other relevant images. So you can see that the disc occupies a large portion of the spinal canal. So the spinal cord is this crescent-shaped gray bit here. When the disc occupies more than 40% of the spinal canal, it's termed a giant thoracic disc. And in this case, it's occupying probably somewhere in the region of 70 to 80%. And you can see it's also fairly significantly calcified. This is not particularly surprising. A lot of thoracic discs tend to calcify, and the giant discs, in my experience, are pretty much always calcified. Another important thing to note is that they are generally, when they reach this size and are calcified, they tend to involve the dura, so they may be transdural or might be severely adherent to the dura. So some interesting things about the thoracic spinal cord is that it tends to run in the anterior part of the spine canal, of the spinal canal, and it's a narrow canal. Also important is that the roots which come out are tethered by the dentate ligament, and it prevents the spinal cord moving away from any compression anteriorly. And the important point is that the blood supply tends to be patchy, and it is in the so-called watershed zone. We discussed the options, and the patient chose to have surgery. The primary goal was to prevent further neurological deterioration. And one of the things we discussed is that she was already quite unsteady on her feet. And we thought that if she were to have a trip and fall, her deterioration might be quite rapid rather than slow. Then the question was, what kind of surgery should be done? So the challenges for this kind of procedure, particularly if you approach it, wherever way you approach it, you are going to have a high risk of neurological deterioration. For any level of thoracic disc, when we talk about the risk of neurological deterioration, if you look at the literature, they quote maybe 7 to 8% of paralysis. And for a giant disc, it's kind of double that. So this particular case, which is occupying 70 to 80% of the spinal canal, that risk was considerable, which I did explain to her. Then the other challenge is that of localizing the level. As you know, in the thoracic spine, it is more challenging than in the cervical or the lumbar spine. And particularly if you're going through the chest, there is a higher risk of ending up in the wrong place. Then the third challenge is that there is often, in my case, I found in my experience, a higher risk of dural tear with these kind of giant calcified discs. So in terms of deciding on the approach, these are the things to consider. Then on a personal note, in Manchester, we have some kind of general ethos that we abide by whenever we're trying to pick a particular surgical route. One is that obviously the work needs to be of high quality, but we are also keen that it be low cost as well as environmental friendly. And I noticed that the logo of your society is equal care for spine, which kind of fits in with our ethos. But if it's not low cost, I do think that it's going to be difficult for kind of low-income countries to do these kind of cases. And this very much fits in with our ethos as well. So for all of these reasons, we decided to do this via the direct lateral, or sometimes called the retropleural extracavitary approach. And I'm hoping to persuade you that these three kind of rules can be applied by undergoing this approach. So the first thing we did was to implant a marker. And I would say this is not something which is absolutely necessary, but in my personal experience, I found that the cost of this is worth it. Often when I do this kind of thoracic disc from the anterior approach, you spend so much time and effort in trying to localize the level that by the time you're convinced that you're at the right level, you no longer have the emotional energy to carry on with the procedure. So I found that putting a pre-op marker is pretty good. So our way of implanting this is via spinal needle. We do it about 2-3 days before the actual procedure. When the patient comes in for a pre-op, it's delivered via spinal needle. A gold marker is implanted. So it comes in as a thin filament, and as soon as it's deployed, it jumbles up and it prevents migration. So the radiologist does this in the angio suite, and so they are able to go up and down and make sure that you have only the normal amount of vertebrae and normal amount of ribs, and so obviously it's a better image. The marker is quite narrow; you can just about see it there. And this is actually an image intensified picture, so it's not big, but you can actually see it very well in under the image intensifier. And we use gold for a particular reason, because gold you can see on an image intensifier, CT, as well as MRI scan. So in some cases, we might go ahead and do another MRI scan to make sure that indeed the radiologist has not made a mistake. But in this particular case, you can see it is just close to the pedicle of the T11 vertebrae, which is where I'd ask the radiologist to do it. And also, especially ask the radiologist to put it on the right side. We normally use intraoperative neurophysiology, and we tend to keep the patient completely normotensive throughout surgery. I think most people in this setting would use intraoperative neurophysiology, and I certainly find that it makes one a bit more aggressive in terms of resection when you're doing this kind of surgery. So in terms of the positioning, it's a lateral approach. And on the left here, I'll just point out some of the useful anatomical features. So this is the latissimus dorsi and the serratus anterior and the external oblique. If you want to, you can break the table, which just makes it a bit easier to get access through the ribs. So again, another picture of the anatomy. So this is the latissimus dorsi, the serratus anterior just peeping in front of it, and the external oblique. In the higher up levels, one does need to be cautious about the long thoracic nerve. So upper thoracic spine, one does need to be a bit more careful. And if you're going through the posterior aspects of the serratus anterior, then definitely look out for the nerve. In the lower levels, it's not such a big issue. So this is the skin incision. It's a 5 centimeter skin incision. So this is the T10 vertebrae, and this is the T11 vertebrae. This is the disc. And I tend to make sure that my skin incision spans this kind of area. And so this is where you expect the disc to be. There are pros and cons in making the skin incision a bit posterior or anterior. If you make the skin incision a bit more posterior, it's actually easier for the approach. The problem will be then you will not have a very good view of the anterior part of the thoracic cord. And for a lot of these discs, that's quite important. These are the bits of equipment which are needed. One is a standard doin, just to kind of make sure that the rib is skeletonized. This is just a rib cutter. And I find this lung retractor blade to be particularly useful. And I personally tend to use a Nuasive X-Lift retractor. Again, I have to stress I have no connections with Nuasive. It's just something I find very helpful to use for this particular kind of procedure. So I use just a monopolar bowie to expose the muscles, and I generally tend to just cut through it. You can split the muscles, but because the skin incision is fairly small, I find it just easier to just cut through it, and I don't find any particular advantage to splitting the muscles. If the skin incision is longer, then definitely splitting the muscle is feasible and gives you good access. And then I tend to cut the rib once you've undermined it and made sure that the neurovascular bundle is free. I tend to use a rib portion about 6 centimeters, so slightly longer than the skin incision, edging posteriorly. There are some approaches whereby you don't actually cut the rib at all, or you can replate it. I personally prefer to just remove the piece of rib. I don't plate it back because I use this rib to morselize it and put it in the vertebral space to aid fusion and to prevent CSF leaks. So the key bit about this approach is this layer called the endothoracic fascia, which is something you find immediately under the rib, under the intercostal muscles, and it's outside the pleura. So this layer in pink. And this is a live view of the endothoracic fascia. So you can see the parietal pleura in this layer. The approach is technically supposed to be outside the parietal pleura and inside the endothoracic fascia. And there is a plane there. However, in my experience, the parietal pleura is often very thin. And if you try and dissect between these two, you end up tearing the parietal pleura. So I tend to go outside the endothoracic fascia. Another advantage of staying outside the endothoracic fascia is that if you're doing, say, the T12L1 level where the diaphragm is, it's actually quite easy. It's not any different to doing it above. So dissecting the endothoracic fascia off the underside of the rib is the key step to it. You need to be patient, and I do find that kind of lung retractor to be helpful in making sure that you have a broad base to apply pressure. You can do it with the finger or maybe with the cottonoid, but like I said, I think the lung retractor is quite nice in that it provides a broad base so that you're not applying too much pressure at one particular point. This is a step I think one needs to be doing carefully. So I take about 20 minutes at least. You can do it under the microscope. It is helpful to have an assistant just to lift the ribs away to one side. So that's the kind of view you would have. So on the underside of this, there is the lung, the parietal pleura, and the endothoracic fascia. And this is a general view that I would have with the retractors in place. You can use these lights. I generally don't tend to use it just because of the expense. So once the microscope is in, you have a good view, your assistant has a good view, and so does other people in the theater, like, for example, the anesthetist. And that's a view, again, with image intensifier. You can use other retractors, for example, an MRI's tubular retractor. But like I said, I tend to use this broader lung retractor purely to avoid puncturing the parietal pleura. So the first step then would be to resect the rib head. And I would say from this point onwards, it is pretty much like a transthoracic approach. So the first step is to resect the rib head, and then you want to make a trench in the upper and lower thoracic vertebrae. It doesn't need to be a big trench, so I generally tend to make it just about 1 centimeter or 1.5 centimeters deep. And I also tend to find it helpful to take the upper part of the thoracic pedicle. If it's a smaller disc, you don't necessarily need to do this, and some people would take the full pedicle. I personally don't find that to be necessary. If you can just tilt the microscope, I find you have enough exposure. But it is very important to be beyond the disc when you're doing this. As you know, it is a fairly high-risk surgery, so you want to make sure that your access is pretty good. If you take the entire pedicle, it's not necessarily a problem, but the patient can sometimes tilt, so then some people will tend to plate it. So far, I've not had to do this. Some people would tend to plate it if it's at the thoracolumbar junction, but again, I've not found it necessary because I always leave a little bit of the pedicle there, and I don't tend to make a big trench. So this is another view. If it's a soft disc, you can just cut it away and everything is easier. But the idea is that you make this trench and then you lever the calcified disc into that trench so that you're not causing any pressure on the spinal cord itself. So here is a view whereby, I'm sorry if the image is a bit blurred, but I've got an instrument in just under the cord, and I'm trying to lever it into that trench I've created. So that's the calcified bit, which is just being levered into it. So this dissection takes a few hours because you just need to do it carefully. And sometimes if the intraop neurophysiology shows changes, then you just need to sit back and just wait for things to come back. It's very important to make sure that the blood pressure remains rock steady and doesn't drop. A lot of the blood loss is purely from drilling into the vertebral body. As you know, it is full of blood. However, you don't tend to lose a lot of blood all over the vertebral body. It tends to bleed just in 1 or 2 places, and you can just use some bone wax to settle that, work in another place, and then come back. Areas where it tends to bleed, it's good to drill fairly quickly, just so that you're not losing a lot of blood. And so once you've drilled, you tend to have this kind of view, which is the spinal cord exposed, and the disc is completely removed. Now, there are people who tend to leave the disc riding, i.e. they detach it from the vertebra and wait for kind of the spinal cord pulsations to push the remaining piece into that trench over a period of a few months. In practice, I found that it doesn't push it in as much as you would like. And another thing to bear in mind is that these kind of patients often will have some residual myelopathic symptoms if they've already presented to you with myelopathy. And if you do a scan and you find a little bit of disc remnant pushing the cord, you're going to be thinking about whether or not that is responsible for it. So personally, I always tend to go and resect the disc protrusion completely. And I accept the fact that you're going to have a dural tear. Now, a dural tear within the chest is obviously something of concern. A normal dural tear in the cervical or lumbar spine is a problem, but not necessarily something which you need to be too worried about. In the thoracic spine, it can be a problem because with every breath, because of the negative pressure, the dural tear is just going to reopen even if you've patched it. However, remember, one of the advantages of doing this behind the pleura is that even if you have a dural tear, it's not going to leak into the chest cavity. And once the lung is expanded, that layer that we've gone through just tends to paste itself back. As I mentioned before, a lot of the giant thoracic discs tend to be calcified and transdural. So if you're going to remove all of the disc protrusion, then you have to accept you're going to have a CSF leak. And sometimes it's just a tiny rent. Sometimes you will have a dehiscence, i.e. I've had cases where you have 1 centimeter of dura missing. I tend to put a dural patch like Duraform or Hemo patch, and then put a dural sealant. And I think one of the key things is to make sure that that your patch doesn't float away. And to avoid that, I tend to put morselized bone graft taken from the rib that we'd shown you before, and you just pack it in like this. So this is morselized bone and a bit of dural sealant mushed together. And that I find has worked, and I've so far not had any troublesome leaks into the chest with this approach. Closure is also important. What I don't tend to put any chest drains. I put a Jake's catheter into the space as I'm coming out. I close all the layers, and then at the very last moment, I will ask the anesthetist to do a Valsalva with the Jake's catheter underwater. And you can see a few of the bubbles coming out. And then I'll just pull the Jake's catheter and close the muscles and the skin with the purse string. So this is the post-op picture. You can see on this axial view, the disc was pretty much calcified and filling pretty much the entire spinal canal. And this post-op picture shows that that's been resected. It also shows you the amount of resection. So it's just about a centimeter and a half. And this is an MRI scan done afterwards. And again, it shows you that the disc has been completely resected. You see a hint of signal change there. And you will notice that the bone has started to reconstitute because of the morselized rib graft. So this is the post-op skin incision, 5 centimeters. So the blood loss was about 300 milliliters, and it took me about 5 hours. And a lot of this time is actually spent waiting, because if you have any changes in neurophysiology, you just cannot rush this operation. So most of this time is spent in doing the bony resection and trying to tease away the calcified disc of the spinal cord. This patient spent 1 day in monitored bed, so it's not intensive care, it's kind of high dependency unit, and the patient was discharged 48 hours later. She's now 4 years post-op, has got 5 out of 5 power. She does have mild pain at the incision site. She still has some spasticity, but this is significantly decreased. She's not on any painkillers and has gone back to work. There can be some complications related to this approach, intercostal neuralgia or incisional pain. You can have a pleural effusion, you can have a pneumothorax, you can have a CSF leak into the chest, you can have wrong lobe surgery, etc. However, the advantages of this approach are, A, you have good visualization of the pathology because it is an anterior approach, and you can see not only the ipsilateral side of the cord, but also the contralateral part of the spinal cord from the anterior part. You don't have much blood loss. You don't need to collapse the lung, so you don't need a double lumen tube. You don't need a chest drain. Less stay in hospital. It's lower cost, more environmental friendly because there are less things that you need to throw away. And that's pretty much what I had to say. Thank you very much. I'm happy to take any questions.
Thank you so much, Joshi. And sorry for I was a bit late, but I'm on call today, so I had to address something else. It was a very interesting presentation and very, very good results. So my question to you is, do you use this approach only for discs, or you've operated something else with that approach?
We've done thoracotomies and we've done XLIFs. So if you want to do an XLIF low thoracic spine, so say T1011, T12-1, again, it's a very, very good approach. And once you've mastered how to dissect the endothoracic fascia, I would say it becomes a very pleasant operation. And it's particularly good at this thoracolumbar junction.
That's great. I was just discussing that I have, so last Friday I did a dumbbell schwannoma at T2-3 with this approach, and I think this is also something that you can use to do that.
Absolutely.
Okay. May I also ask, Joshi, thank you for the presentation. I just want to clarify, I'm as a specialist who was doing a thoracoscopic approach for the bulged disc for the 20 years. I can see some advantages of thoracoscopic surgery in this case, especially because, first of all, I couldn't perform any rib resection. Yeah, I can preserve the rib. It's you avoiding the neuralgia in this case, of course, after operation. Then I would say then performing a thoracoscopic approach for the bulging osteophytes. Theoretically, I can use the another angle and I can resect the adjacent body as much as I need. Yeah. In this case, I'm avoiding dural chairs, and somehow can, even if I need perform some plating, if I need to perform spondylolisthesis at plate fixation. But I'm completely support you for the extra cavitary way, and I just think that's probably we just start to perform for the small lesion. We are doing a percutaneous extracavitary approach with constant irrigation. It's very interesting also way of surgery, and it's probably the mix of the knowledge for this direction could come the very nice final result. I have two technical questions. First, do you use the bone scalpel for the resection? I mean, ultrasound bone scalpel?
You can, and I have used it, but personally, no, I'm not, because like I said, one of my personal goals is to do this in a very low-cost way. And so I just use a normal matchstick drill. And also another thing, absolutely, as you said, thoracoscopic approach. There are people who do this beautifully with the advantages you've just mentioned. Again, I suppose some of the things to bear in mind is that you need a lot of volume, I think, to be good at the thoracoscopic approach. And the second thing is, again, the cost aspect of it. Also, there are some problems with that. But equally, I think it's good to learn all the techniques so that for each case, you can decide which is the best in your hands. So absolutely agree.
Agree. I didn't mention that we use normally 3D thoracoscopic. It's fantastic view. You can feel the deepness. It's very important for the surgery. But thank you. It's a nice presentation. Thank you.
Thank you.
Okay. Any other questions?
Nicola, there are questions on the chat.
From the auditorium.
There are some questions on the chat. Please, if you could have a look.
Unmute yourself, someone.
I'm unmuted.
Now we can hear it.
Okay, so there are some questions on the chat. If you could go through them, please.
Let me just try and find. Okay, yeah. So let me start from the top. Thank you, Mr. Butt. I see a message from you. So there was a message from Faiz Ali Shah asking whether we can use artificial bone graft. Yes, absolutely. No reason why you can't. And can you put PK instead of bone graft? Interestingly, I have done this many years ago. I had one case where I think I hadn't taken the rib cage. I was trying to do it without resecting the rib. And I had a dural dehiscence. So it was not a dural tear. I had 1 centimeter dura missing. So I put a patch and I could see that with each pulsation, this patch was starting to come out. So I thought to myself, I need to somehow prevent this patch floating away. And so that's exactly what I did. I put a PEEK cage. I managed to tam it in place, and thankfully it has stayed in place and is healed. So you could do that. Do you do short segmental pedicle fixation? Krishna Sharma has asked. I don't. You can do. And if you've removed the pedicle, say at thoracolumbar junction, then you have the option of doing either a short segmental pedicle fixation or just put an anterior plate. I think that's possible. But personally, I don't feel it's needed if you pay attention to the amount of bone you're resecting. Then there's a question from Raghavendra. Do you replace the rib? So I personally don't. I use the rib to morselize it because unfortunately, I think for most of my cases, I end up with a dural tear. And so I like to use something to patch it and to prevent it floating away. And I also find it's helpful to attempt a bony fusion. I've not followed up all the cases to say for sure that these cases fuse, but some of the cases I can certainly see they actually fuse. And again, I suppose it's a bit reassuring that it's unlikely to cause any deformity if there is bony fusion. And then again, another message from Raghavendra. Can it be done from the posterior approach with unilateral vasectomy, partial pedicle drilling? Yes. So there is an extra cavitatory approach which can be done with the patient in the prone position. And that is a bit more posterior than what I've described. The disadvantage is that you don't have a good view of the contralateral cord. So for some discs, it may be good if it's towards one side. Central disc, some of them, if it's small, but a large disc, I think it would struggle. And then Adnan has asked, can this approach be used at the low thoracic levels in the junction? Yes, I think absolutely. In fact, it comes into its own at the lower thoracic levels and at the junction. So I think that's pretty much all the questions. Apologies if I've missed out any.
Dr. George, it's very nice case.
You have to unmute
I have
yourself,
a question.
please.
Sure, go ahead.
Do you have used this approach to remove the OPLL in thoracic spine? Because in China, we have lots of kind of these cases.
So it depends on, I suppose, how long the OPLL is. So if it's a short segment, absolutely, it is not. if it's a long segment, you will need a longer access. So I suspect you can use the same approach, but you'll need a slightly longer incision because you may need to tilt the microscope to, span more segments. So yes, I think I've personally never done one with OPLL spanning 3 or 4 levels, but I'm sure it can be done.
Some problem will happen in OPLL cases because usually the dura are classified, and when we remove the lesion, and there will usually tear of the dura, and even dura detect dura will remove apart a lot of dura. So do you think with this approach, the CSF leak will be give some problem?
So the retropleural approach, one of the advantages is that even if you do have a CSF leak, like I said, I tend to patch it and I try to make sure that it doesn't float away. But even if you do have a CSF leak, it is not as problematic as it would be if it is a purely transthoracic approach. So there is a distinct advantage for this. And in fact, I started thinking about this approach after a horrendous case. I had some experience. It was not my case, but one of my colleagues did a case where a transthoracic approach, and he had a nasty dural tear with CSF leaking into the chest. And that patient was in hospital for 4 months. And that's when I started thinking, okay, this could happen to me at one day, and we need to try and see what else you could be doing rather than encountering that particular complication.
Have you ever tried to remove this kind of lesion, this kind of thoracic disc? Just use a transdural approach, open the dura and.
I haven't. It's an approach which is well described, but I think the problem is, the spinal cord in that region is very sensitive. It doesn't really respond well to moving. If it's a very eccentric disc, I'm sure it can be done. But I personally feel for this kind of thing, an anterior approach is better. There are many ways of doing it, and I wouldn't want to say that you should always go anterior. I think there are many cases you can approach it from the back. So it's very much dependent on the particular case. For this kind of case, I would only go anterior. I wouldn't go transdural.
I have used this transdural approach to remove this kind of case, and even short segment of thoracic OPLL, and I found it's also a work approach, and we just cut the dura open from back and push the spinal cord a little and remove the disc anterior of the dura, and we suture the dura anteriorly and backwards.
Fascinating.
Okay,
I think that would be very interesting to watch. Thank you.
Thank you.
Great discussion indeed. I don't know if any of the panelists want to contribute something and would like to do some comments or any questions. Manuel, Onur, any comments? Sandeep?
Yeah, so see, we used to do this approach quite a lot for tuberculosis in the spine. Now we don't get that many, but now, and anyway, even if we get TB, now we go more posteriorly. But previously we used to do this approach quite a lot, and this used to work very well. And now, when Zanchan mentioned about the long segment OPLL, I think instead of going anteriorly, I would treat that as the same as this long segment cervical OPLL, and I would go posteriorly rather than risking and destabilizing the spine over a long segment. And again, dural tears, as Joshi mentioned, they are a challenging thing to do because there is always a risk of fistula, and but most of the time you can just take it pretty well. Duragen or this thing, what you mentioned, all these artificial duras, they do work very well and they stick quite well. In rare cases, when there is still a leak, you may have to do a thick peritoneal shunt but in most of the cases, they should do quite well. But I must congratulate Joshi for a beautiful presentation of the neural disc, which is thoracic disc, which is a very difficult thing to do.
Thank you.
Hello, good evening. Congratulations for this wonderful presentation. Only a commentary. The Barrow Institute, the Dr. Juan Uribe had some publications about the few cases. When you have to open and do the resection, when the fragment of the disc is attached to the dura, after he put the fat graft and put a plate, lateral plate, not for stabilization, only to preserve the fat into the bond, into the hold, and avoid that the fat go to the cavity. And always use a spinal catheter. Thank you.
Absolutely. I think I wasn't aware that there was somebody doing that, but I've just learned from personal experience that the trick to a good dural repair, particularly if you've not stitched it, is to prevent whatever you've placed there floating away. So interested to hear that he was using a plate purely for that. So that's interesting.
Okay, so if there is no other comments or questions, I guess we will transition to the next talk. Joshi, again, thank you so much for your amazing contribution and for a very interesting topic. And as we can see from the discussion, it was intriguing to all of the panelists, and I hope all the auditorium. Thanks again for
thank you for having me.
Right, so I think the next topic will be not less interesting, and it's my pleasure to present Stacey Darvish. Stacey is one of the prominent consultant spinal orthopedic surgeons in Dublin. She has interest in navigation and spinal surgery, and no wonder her topic is subaxial pedicle screw placement in the cervical spine. Stacey, please go ahead.
Thanks, Nikolai. I will try my best to follow on from that excellent talk, but you might get a slightly more orthopedic view. So, as Nikolai said, I am a consultant surgeon in Dublin. This is Mater Hospital, which is the home of our National Spine Injuries Unit, and my home from home, where we do a wide variety of case mix from everything really to do with the spine, including a lot of cervical pedicle screws. So pedicle screws, as we know, are very widely accepted in the thoracic and in the lumbar spine, but they're considered too risky to be done in the cervical spine. Apart from C2 and C7, so C2 was first described by LeConte in the 1960s, and C7 by Roy Camille in the late 80s. And I think we'd all be quite comfortable doing freehand C2 and C7 pedicle screws. The sort of subaxial region didn't really come into sort of favor until the sort of mid-90s when Abumi and Jeanneret started to use them for trauma cases. And that was really when it started to come into the forefront of cervical spine fixation. So why would you choose pedicle screws over lateral masts? Well, we know that pedicle screws are biomechanically better. So there's much lower rate of loosening, greater strength in fatigue testing. You get bigger and better screws when you put them in through the pedicle. From a simple point of view, it's much easier to contour the rod over the junctional regions of C7 and T1. You don't have to skip any levels, changing from lateral mass to thoracic pedicles. Usually you can get away with a slightly shorter construct because you've got such good screw fixation. And as surgeons, we like a bit of a challenge, so therefore we'd naturally choose things that can be a bit more interesting. So pedicle screws. Indications really are the same for all forms of stabilization or fusion from the back. They are excellent for deformity correction because you get such good hold. You can do phenomenal cervical spine deformity correction. So for the Angst-Bond, the Simmons osteotomies, they are phenomenal for allowing that correction. And again, occasionally in those cases where there's either been a previous decompression or the lateral mass are dysplastic, so there's not sufficient bone there for actually doing lateral mass screws or other ankle fixation, then you can usually get away with a pedicle screw. Obviously, if there's indications, there's contraindications. So obviously, if there's a destroyed pedicle, so if it's been fractured or destroyed with tumor, and I'll show you a case of that later on. If there's posterior infection, again, we try and avoid metalwork with the infection. Absent or small pedicles, again, we would try and avoid forcing pedicle screws into them. Your average cervical pedicle from C3 to C6 sort of increases from 5 to 6 millimeters in diameter and about the same again in height. So anything really under about 4 millimeters, you're pushing your luck a bit, trying to put a 3.5 or a 4 mil screw in. And obviously the vertebral artery is both your friend and your enemy in these screws. And so any major vertebral artery anomalies or injuries, you have to be very wary of doing pedicle screws in. The reason we're worried about doing them is for the iatrogenic complications. So vascular injuries, nerve root injuries, or the dural or cord injuries. It's just a selection of papers from 2000 to 2012, looking at around 400 patients. And in that, you can see that there was a vertebral artery injury in about 1%, a nerve root injury in 2%, but thankfully a cord injury was only in about 0.25%. So they're all low rates of injury, but I say significant to the patient if it was to happen. And of note, all of those vertebral artery injuries were all managed just with some bone wax into the pedicle hole. There was no further dissection or no further actual repair required for that. The other thing with complications is you can still blow a pedicle, you can still mess up your screw placement. So you always have to be prepared to convert to another form of fixation. And you can mix your pedicle and lateral mass screws. As I say, it just becomes fun when you're contouring the rod and you have some interesting looking x-rays. So the vertebral artery, why are we aware of this during this these approaches? And it's that the pedicle wall is very thin laterally, so that right up close to the foramen, you're much more likely to breach the lateral wall and end up in the vertebral artery with a vertebral artery injury. So we're aware that the incidence of ischemic brain injury is low if you have a unilateral injury to the vertebral artery, unless it's the dominant vertebral artery, in which case you can have a significant neurological compromise. Unfortunately, most of the time we don't know which is the dominant vertebral artery prior to surgery. And we hope never to have to find out which one is. So you really have to be very aware in your preoperative planning for these screws. You have to be looking for the vertebral artery on your CT pre-op or your MRI pre-op. And if there's any doubt about an injury or any concerns that there may be injury with a fracture into the foramen or tumor, then you have to be prepared to get an angio or 3D imaging preoperatively. So we know that it has a variable course, as it usually comes in at C6, but occasionally there are a few that lurk in C7 foramen, but it is absent in about 95% of cases in the C7 foramen, which again is why we're much more comfortable doing C7 pedicle screws. So if anyone's a member of the AO spine, you may have seen some of these images. This is the technique for doing freehand pedicle screws. I would disagree with the setup for the general considerations picture, because I would usually do this with the arms taped down by the side. And the reason for that being that I want to get as good imaging of my lower cervical spine as possible. And I tend to find that having the arms by the side and pulling the shoulders down, taping them down, gets me an extra level or two of imaging. Pitfalls, as we talked about, would be just the vertebral artery and the anatomical variants that we've talked of. The majority of people who would do freehand pedicle screws would do laminotomies at each individual level that you're planning to put a screw in. Just a small laminotomy that you can feel the medial wall, the superior and the inferior wall, and it just gives you that little bit of peace of mind whenever you're putting your screw placement. Your entry points are actually high and lateral on the lateral mass. So you need to do a very wide exposure and a very long exposure, even if you're doing a short construct. So usually my posterior approach would be just to the edge of the lateral mass. When I'm doing pedicle screws, I'm going out over the edge. You open the cortex with a burr, high-speed burr is usually the way we would do it. And then it's your standard pedicle screw placement. So your pedicle finder in a medial lateral inclination of about 25 to 45 degrees, using a combination of image guidance in the form of x-rays or fluoro and tactile feel. Now, I will warn you that the tactile feel in the cervical spine is not as good and as robust as it would be in the thoracic and the lumbar. So we are a bit more aware of our imaging at this stage. The cranial caudal angulation, you're aiming for parallel to the superior end plate. And then I say, once you've got your trajectory, you feel, you tap, and you insert the screw. Simple as that, but that's not how I do them. So I don't do freehand cervical pedicle screws. As Nikolai said, I am part of a big navigation unit. So I do spinal navigation. So navigation, as we know, first kind of came to the forefront in the mid-90s, where it was done based off preoperative CT scan with a frameless stereotaxy, and it was done for lumbosacral pedicle screws, which, as you can see, had an excellent accuracy of 99.3%, or satisfactory. Obviously, technology has moved on a lot since the mid-90s, so we're now able to do cervical, thoracic, lumbar, iliac screws. We can do loads of corpectomies, all with 2D or 3D fluoro and navigation, allowing us to get the best decompressions and the best fixation. And we're now starting to enter the era of augmented reality, where we're getting 3D imaging in real time. So navigation is definitely the way to go, in my opinion, when it comes to these cases. So I'd like to take you through just a couple of cases, just to sort of demonstrate a bit of my technique and some of the trials and tribulations that I've gone through getting good at these. So this is a 62-year-old man who appeared in my clinic 2 weeks ago. He presented with some mild neck pain when he rotated his neck very rapidly to the right. He got some intermittent paresthesia, occasionally weighing down his arm, again, usually on those rapid rotations round to the right. Although clinically examining him, he was an Asia E. And he has a new diagnosis of pre-differentiated adenocarcinoma, likely of lung, and he also has a past history of leukemia. And I'm hoping these are going to work. So this is his CT. So if you look at the axial there, you can see the grossly destroyed right side of the vertebral body and pedicle. And on the sagittal there, just going to come into view, you'll see the gross instability of the absent half of C7. And I say his MRI scan just confirms that there was no significant cord compression, but there was obviously destroyed pedicle. So this is my setup in theatre. I have an Allen table, which allows me to navigate the O-arm. We have Medtronic O-arm, which I'm not affiliated with. So we do use Medtronic a lot. But I say just we have the O-arm available to us. I say I use the faceplate in this gentleman, which I would not normally do. Normally I would use a Mayfield clamp to provide him with more stability of the cervical spine, but I knew we were going to be down at C7. So therefore I was able to go with just the faceplate because I was aiming for a short posterior fix. So this man who has discussed our spinal metastases MDT meeting, and we felt that he should really have a 360 fusion. So I aimed to do a C7 corpectomy, which I did in standard manner, just supine, straightforward C7 corpectomy. And then because he was junctional, I wanted to do a posterior fix. And also this man's going to go on and have significant amounts of radiotherapy postoperatively. So I didn't want to have his cage coming to any problems and failing and then having to go back through radiotherapy tissue. So that was why he was backed up straight away. So as I say, I usually use a standard approach from the back. I said I would normally use the Mayfield clamp, but I used the facial padding this time around. I use standard dissection technique with a cob or sucker as your retractor, and I'll use my Norfolk and Norwich or my Traverse whilst I'm doing the approach. But before I do my O-arm spin, I switch those retractors to a low footprint retractor. So I use the Gelpies predominantly and tape those down. It's less interference in the CT scan, and also it's much easier then for me to get my drill guide angle right if I don't have a large footprint retractor. And so you always have to make sure you've got your adequate dissection done prior to spin. My trainee learned this the hard way the other week, where I let him do a slightly smaller approach, and he struggled a bit with his dissection. So always make sure you've done your adequate dissection beforehand, and because you cannot risk moving the reference array. There's no room for error in the cervical spine. You cannot have any inaccuracies whatsoever. So you need to have proper dissection. And if you're in doubt, get your drill guide out beforehand and make sure you've got your angles, or able to get your angles before you do your spin. Otherwise you're spinning again. So I'm hoping this is going to play for you all. So this is the sort of vision that you get when you're doing the O-arm spin. It's going to come to life shortly. So we have done one side. You'll see the plate that I put on the front to augment my peak cage. This is the drill, which is referenced off of the drill guide, which is the blue bit. The yellow is the projection of the screw, or projection of the drill tip, which is measured at 16 mils in this case. My trainee was doing these, so I wasn't terribly happy that the entry point was a little bit medial, so I made him reburr it. So you'll see the drill coming back in a second, a slightly better trajectory. So this is him reburring. And then you'll see the drill coming back. In this case, I used Medtronic Vertex Max. We have lots of other implants available, so you can use anything that's just synced up with the nav. So we've lots of different instruments for this. So this is a drill going in. Always high power for these cases, and trust. You just have to trust the navigation. So it's checking your accuracy again all the way through this. But you drill and then you tap. Standard for any pedicle screw. But you can see in this case that you've got a lovely view of this pedicle. And you can see why you'd very comfortably go for a pedicle screw in this case. This is a 3.5 tap. I usually tap to size because I want to make sure I can get that screw. But if you're in any doubt, you can measure it all up beforehand. I opted for a 24 mil screw in this case. Because it's the longest one we have on the set routinely in the 3.5. If I want to go longer, I go up to a 4 mil screw. And you can see there that we're just hugging that medial cortex of the pedicle as we go down, staying well away from our friend, the vertebral artery. It's just the tip of the tap that it's actually referenced. Everything else is just projection. And you're on long lever arms, so you can see that's why it's toggling around a little bit. But as long as you're aware of the tip of the instrument, that's what you're interested in. And also being very aware when you bring your tap back out. The temptation is to stop looking at the navigation and just very rapidly take the tap out, but that's when you can windscreen wiper the instrument and end up in the vertebral artery, which, touch wood, I haven't done yet. So you'll see the screw coming in now. This is very simple for everybody who navigates already. But it's nice to see the pictures. So this is the screw. Again, it's referenced off of you set the reference array off of the screwdriver, but obviously the screws are set standard length. So that's just the screw going in there. And then if we move on to there, so that's his fluoroscopy imaging afterwards. So I just use standard fluoro afterwards. I don't use the O-arm for 2D shots just because of the radiation dose, because I'm trying to minimize it. So you can see the AP in the lateral, and I opted for a peak gauge in this gentleman because I know he's going to have significant radiotherapy, and I wanted to give them a nice channel and to get adequate radiation to him. So he was Asia E post-operatively, thankfully, and I didn't use spinal cord monitoring for him, but I do for any of the complex cases. So this is another case of an 84-year-old who had a fall down some stairs. He was in Asia D when he arrived, just some sensory deficits. I apologize, I don't have his CT scan, but I think his MRI scan will demonstrate his problem. So he was a C7, T1 fracture dislocation with significant edema from the back. So I would normally reduce my dislocations prior to going to surgery. So I put them into J-tongue tractions on the ward, usually overnight, get them reduced and then do a nice 360. For love nor money, this man would not reduce with traction overnight. So I opted to take him to theatre and just did a posterior approach for him. And I actually had to use the pedicle screws to actually reduce them. So I ended up placing several rods, short rods in the thoracic spine and in the lumbar spine, or in the cervical spine, and using rod reducers to actually reduce him. Having done a full fascectomy, he still would not come back. But we got him there eventually. So no further neurological deficit. And I say he's got a decompression now at that level. But also the navigation helps me put screws in every level, so I can put screws in fracture level if the body's fractured, as long as the pedicle's intact. And the third case is just a case of interest, really. It's one of my favorite cases at the moment. He's an 80-year-old man who had a hyperextension injury from a simple fall. He was Asia E. And as is very common in Ireland, they all come with fairly degenerative lumbar spines, or cervical spines, sorry. They all come with fairly degenerative cervical spines. And as you can see here, he's got quite a lot of osteophyte, maybe an osteophyte fracture there, not anything terribly convincing or worrying. The facets all looked fine. So then he got an MRI scan, which again showed a 2-level ligamentous injury at the back. And again, that little osteophyte fracture with a bit of high signal in the disc, but nothing too worrying. So we thought we'd have a go at trying to manage him conservatively. He wasn't the fittest of individuals, so ideally surgery would have not been in his best interest. And so when we got him into a collar and got an erect x-ray, that happened. So he declared himself as being unstable at one level. The higher level of the ligamentous injury is fine. So we went on, he reduced beautifully, putting him back supine. And so we just went on and did a relatively straightforward ACDF and short fix from the back. So we knew we didn't have to fix the higher level because, I say, he demonstrated his stability from that point of view. And so he just got some short fix pedicle screws and an ACDF, and he's now doing great and now free from collar. So my tips and tricks when it comes to cervical pedicle screws, they have to have a preoperative CT. You need to see before you start, do you actually have pedicles to work with? And if you do, how big are they? Do you think you can actually get screws into these? When you're learning, it's lovely to start with stiff spines. So those Eichsbond spines or those dish type spines, because they tend to be much less movement, which means your accuracy stays and you can work from that point of view. Usually I would use the Mayfield clamp for fixing them to the table because, again, it gives me that stability. And if for whatever reason there's broken spinous processes, I can always attach my reference array to the Mayfield clamp itself. Wide dissection and a long approach are definitely the way to go here. This is not one for doing terribly MIS. I say, so this is definitely one for, I say, going very lateral with your approach and go a bit longer so that you can get your soft tissues out of the way to get your trajectories properly. Always err towards the canal rather than the artery, which seems very counterintuitive to start with. We spend all our lives training to avoid nerve injuries and cord injury. So all of a sudden to be putting something and aiming it slightly more medially than laterally is unusual. But I say it's definitely the way to go in this case. Always be prepared to convert. I have some interesting x-rays where one side is pedicle screws, we lost the accuracy, and the other side is lateral mass. So that's always a fun x-ray to look at afterwards. But I say always be prepared to convert or respin, it's not a problem. And navigate, navigate, navigate. I say I am the biggest advocate of navigation. I say my next step is branching into doing these as robotically assisted. But I say certainly at the moment, navigation for cervical pedicle screws. I do them for every case that I can possibly put pedicle screws in the cervical spine. That's what they get in our unit. I say I just get a much better fix and I'm just happy with them. It's the way to go. Thank you very much. Sorry, it wasn't as interesting as the last one.
So I would disagree with Stacey. The presentation was at least as interesting as the last one. I think that is another way to address pathology, and I think that what she said, do pedicle screws if you can, and do it in every case that you can do, so you can get good experience. And when you really have difficult case, then you know how to do it. So I think this is a way to look into this. Any comments, any questions?
Yeah, Nicolai, I think I would disagree. Jeff, generally for stabilizing, putting in pedicle screws without image guidance, I think probably it would be very difficult if you caused a serious problem to defend it, if you've got other alternatives available, and especially for young surgeons when they're starting out and they don't have image guidance. I think it's probably worthwhile looking at other options because other options work equally well. It's been shown there is no difference. Yeah, biomechanically they may be stronger, but they do the trick. So I think safety, if you look at it, and if you don't have image guidance, it may cause serious issues. And, you know, we have had some interesting cases which have caused serious issues in courts. So I think what I'd suggest is, yes, it's a brilliant way of doing it. I really like it. Some of the time I do use it, but, you know, with experience, maybe you can do it. If you have O-arm and image guidance, I think it's the best thing you can do. But if you don't have that, then maybe you have to think twice. If you were the patient and there was that small chance of having a problem, what would you like for yourself? So that's what I say, that, you know, generally for young people, I think they need to start out with simple things. Once they have the tools, yes, sure. I think you have wonderful instruments and you should use them routinely.
Oh, absolutely.
Yes,
so for me, all of my next, because I have the ORM available to me and I have all this navigation, I would fully navigate, and all my trainees do navigation. It's lovely to be able to teach trainees and fellows how to do these pedicle screws. I say, and actually the last case that you saw of the front back with the ACDF, that was done entirely by my trainee. I supervised that. I say, so my trainee, who's a middle level orthopedic trainee, did that case, had really pleased. I can stand and watch him. We know exactly where he's putting the screws, and it's wonderful. But I have never done a freehand cervical pedicle screw in subaxial spine other than in a CAD lab. And I say, don't get me wrong, I think if you have the technique to do it in the CAD, to do it freehand and you're comfortable enough. I was brought up on lateral mass screws because we didn't have navigation where I was training. So therefore I did lateral mass screws. And again, I think the risk of pull out is very small. I've seen very few posterior necks fail from screw pull out. But I say I'm now very fortunate and I'm in a situation where I can do cervical pedicles and I do bigger cases. So I'm doing ink-spawned osteotomies and things, in which case for those, pedicle screws are definitely the way to go. But I agree with you entirely. I wouldn't be rushing to do them as freehand, unless you're very comfortable with the anatomy. And so you can do it very nicely with a laminotomy, and where you can feel the pedicle all the way around, but you're risking still your lateral breach.
I'm myself. I have never advised anybody to do it freehand. So the freehand is something that you may consider if you're very, very, very experienced. But if you're starting, obviously, you would not consider doing that without the tools that you're necessary to have. So if somebody took me, go and start doing the pedicle screws and just forget about lateral mass screws, whatever you have there on the simple X-ray, that was not what I wanted to pass as a message. Professor Sharif, I just wanted to say that if you have the techniques and if you can use it, obviously you have to start with easy cases, and then it's like anything like that. So you start with easy cases, use that for easy cases, and then be good and be possible to do more difficult cases, but definitely don't risk the patient's safety. Yeah, I agree with what you said.
Nikolai, how can you speak with your thing says mute? You're muted, but we can still hear you. What's the secret of that?
That's magic. That's Northern Ireland magic.
Victor is here, who is a great anatomist. Maybe we'll ask him about these pedicle screws and what about the aberrant arteries and the course causing problems. Victor, go on. Tell us something about it.
Hello, how are you? A very nice lecture. I think technology is very useful and very important nowadays. But most important is the selection of patients, of course. And this is very important because in Mexico, we have had some cases where there have been some injuries to arteries, for example, vertebral artery. And I am doing now a study about the cervical arteries coming from vertebral arteries and where is the most important artery going to the spinal cord. For example, I have found in C6 and C7, I have found these arteries. I think I'm going to talk this topic in Athens next November. Now I am very happy to see you all, Manuel Soto, Nikolai Piv, Sandeep Vaishya. Hello, how are you?
Hey, how are you?
I will be in the next week in New Delhi in the World Neurosciences Summit in New Delhi. Are you going to be there?
I'm not sure.
Next week?
Yeah, I will see you there.
Okay. Thank you. Thank you.
Artem and Manuel. Yeah, sorry, Sandeep, go on.
To say something. So Stacey, firstly, I would like to congratulate you for your excellent presentation. And last year I had to do a talk on posterior cervical approaches. And though I have just done 2 cases with cervical pedicle screws, unfortunately, I did not have the videos. So I asked at least 15 of my friends, all with navigation and O-arms, but nobody had any experience of that. So nobody, actually very few people do that. So particularly for that reason, I must congratulate you. Now, I just wanted to ask one question. How many spins do you take during a multi-level cervical pedicle screw approach? Because the margin of error is so small that by the time you have put in 2 or 3 screws, you are not sure whether that there has been any movement or not. Because when we did our first case, we were doing it on an intraoperative CT scan, and we found that after 2 screws, we were losing the accuracy. So we had to do the CT 2 or 3 times, if I remember correctly. So how many spins do you take?
On average, I do 1 spin.
And you are sure of that, just 1 spin?
So I do 1 spin. So usually my setup is the clamp goes, so I have my reference array is set high. So usually if I'm doing say 3 to 6, my reference array is usually on C2, C3. And I start with my C3 pedicle screw because it's the most accurate, and it's also the most awkward one to really get because you're in the smallest pedicle. And I work down from that point of view. Normally, I would start in my navigated thoracic and lumbar. I would start furthest away from the reference array because it's the least accurate, because you're more accurate closer to it. But I check my accuracy in between every single screw. So that's where I get the pointer out, the navigating pointer, and I run it along the lamina, looking at the imaging and make sure that I'm not out. In the thoracic and lumbar, if it's slightly deep, you can usually get away with it because you're talking 5, 6, 7, 8 millimeter pedicles. They're huge. In the cervical spine, if it's out slightly, I'll either spin again or I will convert to lateral mass depending on what I have to do. But I say usually I can get away with a single spin, even for doing multi-level. So I say the other time I have to do 2 spins would be in the very deformed cases. So for the ankylosed neck, so the X-bond sometimes when I'm changing from cervical to thoracic, just simply because of deformity. Because if otherwise you end up at the end just with 2 obliques rather than an axial and a sagittal. And I say 2 obliques is not a great place to be for those converting screws, but usually 1 spin. And I don't do a post-op spin.
So do you do all your holes first and then later on tap them, or you go by individual hole and tap it and then put the screw?
So I work my way. I do the opposite of what you're told to do it 1 each. So do C3 left and then right, or right and left, whichever you prefer. I tend to do all of the right side if I'm on there, and do C3 to C6 and then hand over. And then my colleague, as long as all is well, does 3 to 6 on the other side. But I do burr, drill, tap, screw for every level before I move to the next one. The only time I'll not do that would be actually in sacroiliac screws. That's the one time that I don't do it. I don't do it that way. All of my other pedicle screws are done the standard way. But so usually my accuracy is good enough with 1 spin, but I am OCD when it comes to checking my accuracy. And if there's ever a doubt, I either respin or convert to lateral mass, depending on what the indication is.
Okay.
Joshi wants to say something. Can we just unmute him, please?
Thanks, Stacey. That was a lovely presentation, and I'm also a firm believer in pedicle screws. I had a general comment and then 2 specific questions, if I may. One is, as people have mentioned before, that there is obviously, lateral mass screws definitely do the job for most cases. The pull-out strength, from what I understand, of a cervical pedicle screw is double that, almost double that of a lateral mass screw. So there are some instances where they definitely are better. So you could have a situation where you're working with someone and they ask you for help because they've broken a lateral mass screw, and you come over and then you break one, and then now suddenly you have to have a very different operation. So that's a very good example whereby, having the ability to put a cervical pedicle screw can prevent you from going very long. And if it's a young patient, definitely that is an advantage. And then the other is maybe if you have, say, facet dislocation, etc., you can still keep the construct short. So one comment for perhaps younger surgeons I would make is that, so when I was training, even when I'm putting lateral mass screws, if I'm going to C7, I always would put in a pedicle screw, because the lateral mass 7 is smaller than the other lateral masses, and B, obviously you don't have the vertebral. So it's a good area to practice, and obviously you need to make sure that you've looked at the scans carefully to make sure there is no aberrant artery going at C7. But I found that's a good way to get comfortable at pedicle screws, because you don't want your first pedicle screw to be the one where it's a high risk case at say 3-4 or something like that. So that's just one comment I had. The other is actually at the beginning, I have two questions, if I may. There are, at the beginning of your talk, you mentioned you have a spinal MDT, spinal metastasis MDT. Is that correct? It's purely yes. For metastasis.
It's a spinal, so we have a spinal metastases, or we do discuss the occasional primary tumor at it, but we do have a METS meeting every week, every single week with ourselves as orthopedic surgeons. The neurosurgeons are invited, and say radiation oncologists, and anyone from across the country brings their case, presents their case, and we get a decision made as to whether we should be proceeding with surgical fixation prior to radiation or going straight down the line of radiation. So we've got two very, very enthusiastic radiation oncologists who are at the meeting every week, but highly recommend having that. I say we just do it by Zoom now on a Wednesday evening for half an hour to an hour, depending on how many cases, but every week. Yep.
Excellent. It's really great to hear that you've set that up. So most places would have a spinal MDT, but I'm interested to hear that you've got a spinal metastasis MDT, which I think is absolutely the way to go. The other thing I want to mention is that, so you mentioned you need a very long incision because your entry is quite lateral. And I wondered whether you've come across any kind of sheets that you can use to kind of get through that problem.
So I am dabbling with the idea of starting to do them percutaneous now, but I think we'll have to start branching into that in the very, so I'm going to start that in the very stiff spine. So unfortunately, most of my ankylosing spondylitis fractures at the moment seem to be dislocated, so they're not the best ones to start with. But I'm going to start dabbling into doing them, I think, in a stiff spine, hopefully in a short fix percutaneously, all being well, and that would negate the massive muscle strip. But as we all know, posterior neck, you always end up being slightly longer in your incision, even if you're only doing a short fix. I still try and keep it as short as possible, but sometimes you have to go. You do what you need to do to get the exposure and the angulation. But I don't have any major tips and tricks to negate doing a bigger approach.
Excellent. I wonder, any of the audience have come across a sheaths kind of thing that would be helpful in this situation, just to try and reduce the skin incision?
Yeah, I think we have used them in few occasions, but we have these plastic sheets that we make it ourselves, so it's taken from different kind of tubes, and it works very well. And especially with MIs, it works quite good. Again, I'd say that yes, but if you have to practice, just practice on C2 and C7 where it's easier compared to other levels, please, before you start doing this freehand. And we know that. I think patients are more important than us doing macho techniques. I would still, I'm quite firm believer in that. Sorry, Pablo, you have any comments?
Well, I really, I don't have navigation, so for me it's really easy to choose, but so I think it's very difficult to do the freehand, but when I have to do it in 3 cases, I just do the laminectomy. So it's the way that give me more stability to put the screw. But I think it looks easy, but in the OR, as everybody says, you have to be very quiet and take care of the patient, because you have to know very, very, very about the anatomy and the steps, and sometimes it's really a big trick. So I do the classical technique, and hope that for the moment I will stay in this standard.
Manuel, would you like to say something, please?
Yes, congratulations Professor Stacey, I think it's possible with MIS, with tubular retractors, no expandable retractors, to put the screw. If you have a navigation, you can do the planning since the skin. See, the muscle is possible to navigation. So the difference is that you put the antenna in the Mayfield clamp and not put in the SBNS process, and it's so secure. And maybe you can begin with a mini open, lateral mini open, and the dissection, open dissections of the fiber muscles, and then you can do the navigation and avoid the midline incision. Thank you.
Thank you.
Imad, can you show us the answers of the multiple choice questions, please? Oh, so we don't have the questions here. So whose multiple choice questions are these?
I think
Joshi?
these are mine. I think
Joshi, you want to take them and maybe describe and then see what kind of answers people have given. Have they understood what you have explained to them? Let's see.
So that's the latissimus dorsi, which most people have identified correctly. So it's just kind of the muscle that you have to cut through for this kind of posterolateral thoracotomies. So it's important to know that. And the second one, I can see there is a difference in opinion, which is for a lower thoracic discectomy via an anterior approach. Would one prefer a right-sided approach? And so I think around 60% said no, you would prefer a left-sided approach, but I can see this 40% would say they would. I personally would always prefer a left-sided approach for lower thoracic for two reasons. One is the liver is on the right side, and hence you'd find it difficult to push it down. So the right side is technically more difficult in that respect. And B, on the left side, you have the aorta rather than the vena cava. And if you have an injury of the aorta, it's easier to deal with than the vena cava, which is thin and friable. So I think if you look at the literature, most people would prefer to go via the left side approach for a lower thoracic discectomy. Can you scroll down, please? So most cysts are actually central. So that's something which is unique about the thoracic disc protrusions, and hence why a lot of surgeons prefer to go anteriorly rather than posteriorly for this. And then the last one, thoracic disc protrusions, they are quite rare. So they are actually less than 1% of all disc protrusions. So again, I just thought it was a useful thing to know. Thank you.
Right, so I think next one will be Stacey presenting the MCQs, yeah?
Yep, so this is what is the optimal range for the mediolateral inclination for subaxial pedicle screws, and the answer is 25 to 45, so B. So the majority got that. Less than 4 millimeters is considered generally too small for putting pedicle screws in, but you could argue either way with that. But I say 4 millimeters is a sort of literature approved number. I say the majority of pedicles are 5 or 6 mils when you measure them out in the cervical spine. So less than 4 is pretty small. So you'd be really rethinking that one if that was the case. And then which of the walls is the thinnest? That is the lateral wall. That's why we get so worried about the
Mark, can you scroll up, please?
Down.
So down, down, down.
And down one more. So the lateral wall is the thinnest wall, which is why we err towards the medial. So we err medially, despite the fact that the cord and the nerve root are medial, you do actually err towards the medial side because the thinnest wall is the lateral and you're much more likely to breach that. And what percentage of patients does C7 not contain a vertebral artery? So just the last one. Officially, it's 95%. But as we say, we know that there's quite a variation in the anatomy, but I say 95% in theory do not have a vertebral artery, but that does not mean that you can trust that your patient does not have one. You have to go looking to make sure you're not in that 5%. So well done to everyone who got those right.
Matt, can you show us what do we have in store for next week?
Yes, sir.
This is evening. I'm sure you're not sleeping at this time.
Okay, so this is something that we're planning for the next weeks and months. So we wanted just to let you know, so you'll be interested and you participate in that. We have in August, so that's next week. The next weekend, we will have the Student World Neurosurgery Conference. So you're very welcome to join us and to see the presentations by renowned specialists in the area. So again, this is something that is must to see, and I strongly advise you to be with us next week. As you can see, many have the faces you will recognize straight away, and we don't need to tell you who those are and what they will present to you. Okay, let's go ahead, Matt. Yeah. So following that, on Sunday, the 4th of September, we are planning the next course from the OR. On thoracic spine. This is also an event that I strongly advise you to attend if you would like to increase your expertise in thoracic spine. There will be many good presentations and you will have a lot to learn. Next one, please. Yes, and finally, this is the last book that we have published. This is a book that was published by the World Spinal Cord Society with the help of the many of the members of the World Spinal Cord Society. We continue the series. This is a book that is going to be available from our website for our members. So if you would like to have this book, become a member. And so this will be not only that book on your disposal, but many other online educational materials, which you will have for free. So please consider that. We keep preparing other books and other online material as well. So the next book that is coming will be on spinal tumors. And that is from me. Finally, if anybody at the faculty can say something, although Salman was keeping me muted, I was still finding a way to speak. So, but that's it. I finally will stop and I will give the word to somebody else.
I think it was brilliant. I think everybody contributed. I think brilliant talks. Both talks were very, very good. Stacey, Joshi, I think, we really enjoyed that, learned loads. Always a new trick that you learn. Can everybody switch on their camera so we can have a group photograph, please? I see Nasri as well. Yeah, great. Please switch on your cameras. Oh, I see a lot of old friends here as well. Brilliant. Also, we'd like to thank James, who has been translating this telecast to China. So this is going live to China, where it's being translated by James with the help of Zenchen, who's very kindly arranged that last minute. So we are grateful for that. And it's really nice, and hope to have more contribution for China as well in future. Yeah, can we all have Nasri? Can you please switch on your video? We'd be grateful. Yep, brilliant. Okay, thank you. And everybody can smile.
Thank you.
All right, thank you, everybody. It's brilliant. Sandeep, you want to say a few words before we close?
I just wanted to say that the next week's session, though it is meant for medical students, but I think it is going to be a great session, and I would invite everybody to log in and spread the word and ask your trainees and medical students to join in. And so that's all.
Okay, thank you, everybody. That's closed. Brilliant. Nice to have met you all again, and hope to see you next week and the week following. Okay, take care. Bye-bye.